So hello everyone. Thank you for joining us. We have a nice case today I want to share with you. So this is a 62 years old woman that was admitted in another hospital because of acute pancreatitis with a pseudocyst persistence. She received a drainage by US in other hospital of the cystic lesion using plastic stents. So you can see in the bigger picture the X-ray. You see the double pigtail that they put it. They solve the pseudocyst from the tail, but it's not completely from the body. But it's not completely uh, solved. So it's still a persistence. And I see two things interesting in this case. First, this patient is not. You can see the image there. This is a chronic pancreatitis. You can see there is a hypoechogenic area of the pancreas. Practically, you see the 5.1 millimeter of the diameter of the main pancreatic duct. And second, when I was looking here, I didn't see it a little bit, but when I was looking inside, I saw it a communication. So that's why there's still a persistence of the pseudocyst. So what we need to do in this case, first a good diagnosis. I believe this is a perfect case to show it that probably the US was not well done because this is a chronic pancreatitis first. Second, when you have a chronic pancreatitis, a pancreatoscopy is mandatory, but in this case I want to move forward and I need it to go inside because I see it, a stone here that I believe is here. So when you see the ERCP, con la geografía en grande por favor, ahora sí quiero ver la imagen acá. So I see the shadow here, this is the stone, yeah, okay? So I see the shadow and you can see the stone there, but also there is still you see how there is a disruption, of the main pancreatic duct, and that's why we need to make a second drainage, but this drainage needs to be done through the papilla. It means we need to make a sphincterotomy and put a stent inside the pancreatic duct, for diminish this risk. That is the second situation. And third, we need to retake the patient for make a lithotripsy of this stone because this is the cause, the chronic pancreatitis is the cause of this problem right now. So what I did was completely, quickly and faster because the main pancreatic duct was very dilated. And in those cases, I believe it's much better to make a pancreatography, right? Using US. It's quickly, faster, and I will diminish the risk of the patient. Dame más contraste. So I want to show this. I believe this patient needs to be evaluated also by pancreatoscopy, not just because of the chronic pancreatitis. You can see here the complete disruption. So now when I use it at 22 gauge needle, I will use a 19 gauge needle, or I will make my ERCP. So I believe I will change to an ERCP right now. I believe will be much better. But we need to evaluate also. Ten aquí. You see this is a stone here on US, right? En grande la echo. Look this main pancreatic duct. You see? It's almost nothing of pancreas. So the other possibility is the coexistence of IPMN inside. So this is why it's very important to evaluate. It's here, you see. I'm trying to see the tail of the pancreas now. So here's the collection, you see? So this is the kidney. This is part of the pancreas. I'm trying to look in. This is the stents. You see the stents here? These are the stents. So there's no more collection in this area, but there's still, you see, fluid going there. That's why she's not developing more, but this is because she still have the stents. So I will not remove those stents. I believe I will not make another damage in the patient. No, it's not the damage, but I will not make a unnecessary procedure, right? And now I need to evaluate the head of the pancreas. So we can see here. Okay, so now so this is a big stone here. Big stone. Vamos a ver. So I believe this is the gallbladder with a big stone. This is why we cannot see very well. This is the shadow. That's why. So this patient have a. This is a difficult case, huh? So this patient need surgery for sure of the gallbladder. There is a chronic cholecystitis also inside. I saw it. I will show you in a few minutes. Real, very difficult, huh? I will pass a little bit more. Okay, now let's see the uncinate process. It's still delayed, you see. So it's affection of the whole gland. But this is a pseudotumoral pancreatitis, chronic pancreatitis. This is pseudotumoral chronic pancreatitis. You can see here, so the risk is high. The risk is high for cancer, so we need to take a biopsy from this area, for sure. It's in between the head and the uncinate process with the still start this situation. You can see here the hypocogenic area here. You see I will use DFI. So there is no vessels, you see? What I see so probably it's still because of the acute crisis that she have, but I'm not so sure. I need to have a histology from this area, but for sure she have a chronic pancreatitis. There's still some liquid here, you see? So okay, let's see again. So I believe will be a difficult cannulation by ERCP, but we will try for initially from that area. There are some hypogenic areas. So this is a complete evaluation. You see, this is a tumor here. ¿Esta paciente ha perdido de peso? ¿Ha perdido de peso? So she lose weight. So I believe probably this is a pancreatic cancer over chronic pancreatitis. This is my regard. So she lose weight. Could be because of the chronic pancreatitis, but I believe we need. ¿En marcadores tumorales? Ya, préstame para tomar biopsia aquí con la aguja 22. So I will use a 22 gauge needle, the same one that I used it. ¿La purgaste? Yeah. So I will take a biopsy from here, and then I will try to make a drainage by ERCP initially. If not, I will make antegrade. So there's a lot of work here. So I want to show it how to see all the things that we can do by US and what we need to evaluate correctly in this kind of patients. This is very important, very important. If you don't have a good diagnosis, you know, you can drain. Yes, you can drain for sure. Whatever, whoever people could, you know, that is trained can do it. But no, it's not about what you can do it. It's about to make a good diagnosis first, and second, to avoid complications and to make a good solution for the patient. This is the most important. So now you can see I am inside the mass. And now I am taking biopsy from this area. This is the hypoechogenic area. So this could be a pseudotumoral chronic pancreatitis versus adenocarcinoma, but it's very clear the tumor here. So probably this is the evolution of the chronic pancreatitis that she had, and probably never she was diagnosed. That's why probably in the future the use of adaptive ultrasound machines in the tip of a standard scope for general GI will be a very good decision, and we need to change the way that we train in our physicians, because in that way we can have much better diagnosis and increase at least in 30 to 40%, as has been published in other papers, you know, increase the diagnosis. However, the US is very expensive as it's known right now, but right now it's really cheaper in terms of, you know, when you're comparing the techniques or the technology that we are using, you know, right now with endosound, I believe can have a very nice and bright future, you know, but we need to make studies, we need to discuss, we need to do a lot of things, so it will take some time, but I believe it's not so far. So I will finish here my transmission. I want just to show the US. I will continue working here, and then if I have time I will try to show it the results.